All over the world, there are 200 million pregnancies each year. With pregnancy comes a bouncing baby, but it can also result in many postpartum complications. Some of the most common postpartum muscle dysfunctions are incontinence, pelvic organ prolapse, sexual dysfunction, and diastasis recti. All of them are pelvic floor disorders except diastasis recti, which is a musculoskeletal disorder. In the US, the cost of care of postpartum muscle dysfunctions is more than $1 billion a year. The high costs are mostly related to the surgeries done to correct chronic muscle dysfunction and the resultant symptoms. As many as 1 in 7 women will undergo surgery for these conditions, and with such a large medical and economic burden, we need to think about other ways to lower the costs to help women earlier with less invasive methods. In order to recognize these conditions in your patients, it's important to understand what is involved with each of them. Postpartum incontinence is the urinary and fecal incontinence that occurs because of the physical and hormonal effects of pregnancy and childbirth. It involves increased voiding the bladder and decreased control for voluntary voidance. Other symptoms include incomplete emptying and slow stream. Urinary incontinence can be in the form of functional, stress, or urge. Fecal incontinence involves both stool and flatus. As many as 50% of postpartum women experience urinary incontinence of some degree, and 17% of them experience fecal incontinence. Pelvic organ prolapse occurs when there is a herniation of the anterior or posterior vaginal wall, uterus, or vaginal apex into the vagina or through the vaginal opening. These can be caused by the descent of pelvic organs such as the bladder, the rectum, or uterus. While most patients with pelvic organ prolapse are asymptomatic, the most common sign is feeling a bulge that protrudes to or past the vaginal opening and discomfort. There are 3 stages of a prolapse. In the first stage, the cervix remains in the vagina. In the second stage, it appears at the perineum or protrudes on straining. The third stage involves the total protrusion and inversion of the uterus. Stage 1 and 2 can be treated conservatively, but stage 3 usually requires surgical intervention. After their first vaginal delivery, up to 50% of women demonstrates a mild prolapse, which can be stage 1 or 2. Sexual dysfunction is a group of disorders characterized by disturbances in a person's ability to respond sexually or to experience sexual pleasure. It can be physical, social, or psychological in nature. It can manifest in patients as a dysfunction in sexual desire, sexual arousal, orgasm, and pain during intercourse. Up to 64% of women experience sexual dysfunction within the first year postpartum. Diastasis recti abdominis is a partial or complete midline separation along the linea alba of the 2 rectus abdominis muscles. The separation is measurable by finger widths. 2 or more is positive for this condition. Women with diastasis recti are more likely to have higher degrees of recurring and persistent low back pain and pain in the abdominal and pelvic region. At 6 months postpartum, 45% of women experience diastasis recti, and even 1 year postpartum, 32% of women still struggle with it.
These conditions are all a result of the anatomy and physiology of the pelvic floor and pregnancy. The pelvic floor is composed of muscles and connective tissue that create a sling or hammock from the pubic bone to the coccyx. Together, these muscles support the internal pelvic organs and protect them from the effects of gravity. They are a key component of the core muscles that aid in pelvic stability for spine and hip mobility. The pelvic floor muscles also control outward flow from the rectum and urethra, maintaining sphincteric pressure and the colorectal angle for continence. During increased intra-abdominal pressure, the pelvic floor muscles contract around the urethra and anus to prevent leakage. Similarly, to urinate or defecate, they relax to allow passage without straining. These muscles are also important during sexual arousal and orgasm, as sufficient pelvic floor muscle strength is necessary for orgasm. During pregnancy, the pelvic floor muscles support the fetus in utero and help it navigate the pelvic girdle during birth. As the fetus grows, the pressure on the tissues of the pelvic girdle increases, causing the body to release a hormone called relaxin in the last trimester to increase pelvic laxity to allow passage of the baby through the vaginal canal. During childbirth, pressure of the baby against the cervix and pelvic floor tissues stimulates the release of oxytocin, a hormone that helps to stimulate powerful pelvic floor contractions to move the child along in the birth canal. The pathophysiology behind pelvic floor muscle dysfunction arises from multifactorial physiologic insult from pregnancy and childbirth. The muscular, connective, and neural tissues of the pelvic floor are subject to these numerous anatomic, functional, and hormonal changes. During delivery, stretching and weakening of the muscles and connective tissues of the pelvic floor can lead to laxity and insufficient support for the pelvic organs. Furthermore, damage to the pelvic floor tissues can occur with spontaneous tears during delivery. Stretching of the muscles or tearing can also damage the pudendal and pelvic nerves. This can result in poor contraction of the urethral or rectal sphincters to maintain continence during increased intra-abdominal pressure like coughing or sneezing. These changes can result in functional stress or urge incontinence, as well as pelvic organ prolapse or sexual dysfunction in women.
During pregnancy, the presence of relaxin increases the laxity of the connective tissue of the abdominal muscles. As the fetus grows in size, some separation can occur along the linea alba of the rectus abdominis. The separation can be partial or complete. It can also occur during delivery as the woman bears down to push the baby through the birth canal. With pregnancy and childbirth having such a complex effect on a woman's body, it's essential to be aware of these conditions because they will be common in postpartum patients. While some of these conditions are usually thought of only in the context of women's health physical therapy, at some point in their careers, all physical therapists will probably see postpartum patients. Because many of the pelvic floor disorders still go unnoticed and untreated, it is important for any provider to be able to identify who might be struggling with pelvic floor muscle dysfunction. Physical therapy is an opportune time to ask questions or have a questionnaire that will help identify more of these patients. Key questions include: do you leak urine when you lift, cough, sneeze, or stand up? Do you get up at night to urinate? How often? Do you go to the bathroom more often than every 2 to 3 hours? How much water do you drink in a waking day? Are you constipated? Do you see or feel a bulge in your vagina? Being aware of these conditions and symptoms can help us to identify patients early in their conditions for treatment, or refer as needed.
These are some recommendations for generalists when approaching postpartum patients. If a patient has a musculoskeletal complaint after pregnancy or just requires some general strengthening of the pelvic floor, a generalist can treat them. The key is to be aware of this list of red flags that would indicate your patient needs a women's health physical therapist. Additionally, a provider can always consult with a specialist if they are unsure or have questions about treatment approaches or determine if the patient needs a referral. In general, the treatment options for these four conditions until recently have involved primarily surgical correction or use of medication. With surgery and medications, though, there are always risks and possible complications, so it's an option that many will prefer to avoid if there are conservative treatments. Thankfully, there's emerging new research detailing the benefits of pelvic floor muscle training, biofeedback, surface electromyography, education on body mechanics and intra-abdominal pressure management, and bladder retraining for the pelvic floor muscle dysfunctions. For diastasis recti, there has been good research detailing the benefits of a deep core stability strengthening program, with use early of abdominal bracing as necessary. Because so many women go undiagnosed and untreated for pelvic floor muscle dysfunction, it is important to recognize that these disorders can be worsened with improper core strengthening or exercises that increase intra-abdominal pressure. This is why the screening questions and red, yellow, and green light recommendations are so important for all providers, especially physical therapists, to be aware of.
In addition to new conservative treatment options, there is growing research on risk factors and prevention. In general, many risk factors for postpartum conditions are due to pregnancy and childbirth. The risk of pelvic floor damage is estimated to be 2.9 times higher after vaginal delivery than C-section. Other non-modifiable factors can include episiotomy, increased weight and head size of the baby, prolonged labor, and other chronic diseases. However, the research has found that there are many modifiable factors that you can talk to your patients about to prevent postpartum conditions from developing, such as obesity and inappropriate heavy lifting, frequency of sexual activity during and after pregnancy, It's important to also screen for postpartum depression, as that can affect the development of these disorders and whether or not women seek early treatment. Overall, together with interprofessional collaboration and education and openness to talk about pelvic health, many women can be treated earlier for these conditions, thereby reducing the economic and emotional burden that comes with these conditions.